Good afternoon, everyone. Thank you, Dr. Shastri sir, for setting the context for this meeting on lipid-lowering therapy. And you have rightly pointed out that almost 80% of the patients whom we have today do not achieve their statin goals, lipid-lowering goals, even after high-intensity statin therapy. And that's why we are standing here today to explore what are the other probabilities we have, what are the options we have in managing these patients. He has rightly pointed out that recurrent events happen in ACS patients and it happens in the first 90 days. A second MI, another event like non-STEMI or a heart failure do occur in the first 90 days for these patients, and this is the vulnerable period wherein we need to strike hard, strike early. That was his last slide. So it's very important that recurrent events have to be given their due importance, and 1 in 10 patients have reported a second MI, a stroke or a CV death within the first 100 days after experiencing an MI. And contemporary registries with the NSTEMI, NST, ACS have shown rates of death, MI or recurrent ACS exceeding 10% at 1 year. So it's very high event rate. So that's the reason we said strike early, strike strong, and from early to aggressive management of this dyslipidemia. The ACS patients are at a higher risk for a future event, and the guidelines recognize this very much, that early intervention is critical to improve the symptoms. As a general guidance, lipid profile should be obtained as soon as possible after the admission, probably within 24 hours, and the lipid-lowering therapy should be initiated again in the emergency room, wherein when you start loading them with your dual antiplatelet therapy, that is the time I would load my patient with a high-dose atorvastatin or a rosuvastatin. And then we need to continue the drug and educate the patient for a lifelong adherence to the therapy, preferably a high-intensity statin therapy because he had an acute event there, depending on the patient tolerance and tolerability there. The lipid levels, as rightly pointed out, should be reevaluated at the end of 4 weeks after an ACS event, and to determine if the treatment goals have been achieved, and check for the safety values. Does he have a rise in CPK? Does he have any symptoms which he would silently stop his drug because he has significant myalgia or muscle pains there? And probably you need to adapt and adjust the treatment regime in such a way that the treatment LDL goals are achieved. How do we ensure the access to this early intervention? The claims process for coverage under pre-hospitalization health insurance products. This is one area wherein we need to work on it. I think we will talk with the company people. But what is the role of this LDL variability in cardiac adverse events? This is a very important topic. We have a lot of patients, when you start your statin therapy, they start lowering their LDL cholesterol. But subsequent visits of 4 to 6 weeks or 2 or 3 months, you find that the LDL levels vary. The first visit probably it's 120. You hike your dosage and he comes back with a blood LDL cholesterol level of 80 or 70. But then the subsequent visit at 3 or 4 months, the LDL has jumped back to 120. Then you start questioning whether the patient is compliant, he's adherent to this drug therapy. Yes, he is adherent, he is compliant, his spouse says he's been taking his pills very regularly, but still you see visit to visit LDL variability, and that is the crux of the issue there, why we need to think of alternative therapies. The most important thing is that the LDL variability itself, visit to visit clinic LDL level variability, is an important predictor, independent predictor of cardiovascular events, and the evidence over the last 30 years indicates that dose-dependent, log-linear association between LDL exposure and the risk of ACVD. The longer the person or the vessel is exposed to the higher LDL level, the higher the level it is exposed to, and that's where the plaque accumulates. The plaque accumulates and reaches a threshold wherein it starts encroaching into the lumen and will have further cardiovascular events. So LDL variability increases the risk of cardiovascular events. Not added my slides. Yeah. So you have this group here where they started on statins, and by day 180, a lot of patients had a reduction in LDL cholesterol, but this is a group wherein they had a rise in the LDL cholesterol. Vis-a-vis inclisiran, which I will come to in the subsequent slides, 2 doses of inclisiran, and you have a significant unimodal drop in the LDL cholesterol levels. And at day 180 and day 240, you see the same consistent benefit what you've seen there. So we know that reduction in LDL cholesterol does reduce cardiovascular events, and 1% reduction in LDL cholesterol does make a major impact there. So increase in LDL variability also increases the risk of cardiovascular events, and about 16% have an increased coronary event, 11% have any cardiovascular event, 23% have death, 10% have an MI, 17% have a stroke. So the real world event reports that a progressive lowering of LDL cholesterol variability significantly reduces the risk of cardiovascular events and all-cause mortality there. So what are the novel therapies like inclisiran which are available today to fit in the current lipid lowering space? So this is how the evolution of lipid therapies have happened. We started off with statins, statins basically, and then ezetimibe, icosapentine, bempedoic acid and fibrates as an oral combination, moved on to monoclonal antibodies, and then to antisense oligonucleotides, silencing RNA, vaccination and gene editing. I think we are going to see this, all of this in our lifetime. So since the discovery of this PCSK9 molecule in the regulation of low density cholesterol receptors in 2003, a paradigm shift in the treatment of hypercholesterolemia has occurred. The PCSK9 secreted into the circulation is a major downregulator of the LDL receptor protein as it chaperones to the endosomes and lysosomes for degradation. So targeting the PCSK9 we have at the plasma level, at the PCSK9 expression and PCSK9 secretion levels, and the silencing RNA acts at the PCSK9 expression level. So inclisiran is one of the first silencing RNA therapies we have for an effective LDL cholesterol reduction, especially is a selective taken up by the hepatocytes with the help of a specially designed GalNAc conjugate. Stored within the endosomes, inclisiran is slowly released into the cytoplasm where it loads onto the RNA-induced silencing RNA complex or the RISC complex and leads to the cleaving of the messenger RNA, which promotes the secretion of the PCSK9, thereby reducing the PCSK9 levels and increasing the number of LDL receptors available at the surface there. So the silencing RNA mechanism differs from that of monoclonal antibodies in that it is linked by a ligand called GalNAc, which specifically binds to the ASGPR receptors found on the hepatocytes only. Thereby it facilitates the targeted uptake of inclisiran by the liver. So the lowest yearly medication burden with a potential for better adherence and a lower LDL exposure is seen when you have 2 injections per year vis-a-vis the monoclonal antibodies where you have 26 injections per year vis-a-vis statin therapy where you need to take 365 pills per year. So what are the salient clinical evidence and guideline recommendations for inclisiran is that ACS patients again are at a higher risk of the future event. I think we've gone through this. The comprehensive clinical trial program what we have, phase 1 we had Orion 6, 7 and 12. Phase 2 we had Orion 1, 2 and 3. Phase 3 trials 4, 5, 8, 9, 10, 11. Victorion 2 Prevent and Victorion Plaque have been released. The 9, 10 and 11 were basically patients who have familial hypercholesterolemia, stable on low-fat diet with an LDL cholesterol of more than 80 milligrams per deciliter. Orion 10 was for patients who had ASCVD, coronary artery disease, cerebrovascular disease and peripheral vascular disease. And Orion 11 were patients who had ASCVD risk equivalents also, and the LDL cholesterol is more than 75. So the co-primary endpoints of placebo-corrected percentage change in the LDL cholesterol from baseline to day 510. And the pooled analysis has very clearly shown that there is a significant 26% reduction in MACE events compared to the placebo over 18 months, fewer MACE compared with the placebo, numerically lower events of MI, numerically lower events of stroke. These exploratory outcomes offer early insight into the potential cardiovascular benefits of inclisiran and suggest that this approach may provide a significant cardiovascular benefit. The pooled analysis of this Orion trials 9, 10 and 11 has clearly shown a sustained 50% reduction in the LDL cholesterol, and even the total cholesterol there is a 30% reduction, non-HDL cholesterol a 42% reduction when compared with the placebo there. The apoprotein B also there is a 40% reduction. The Orion 18, which was a phase 3 trial to evaluate the efficacy and safety of inclisiran at 330 day in Asian atherosclerotic cardiovascular disease or high-risk ASCVD patients, about 345 patients studied, 57% effective LDL cholesterol reduction and a sustained 56% LDL cholesterol reduction at day 360. So there's a significant reduction in the LDL cholesterol levels, even in the high-risk Asian ASCVD population there. So inclisiran first strategy was one of the concepts which has been come in effectively to reduce LDL cholesterol as early as possible, especially after an acute coronary event. And so the inclisiran first strategy was with the Victorion Initiate trial. The change in the LDL cholesterol from baseline to day 180, 330 was about 53% significant LDL reduction, and it was a sustained when compared to the usual care, wherein there was a significant drop in the total cholesterol, non-HDL cholesterol, VLDL cholesterol, triglycerides, ApoB, and lipoprotein A marginally there. So inclisiran as a molecule offers a good safety profile. The Orion 8 demonstrates a long-term safety. This was followed from patients from 4 previous trials, 3, 9, 10, and 11 Orion series. For up to 3 additional years, they were followed up for a safety profile. It is safe in renal and hepatic impairment. There's no drug-to-drug interaction. There's no off-target effects because there's no clinically significant differences in efficacy and safety profiles in patients who tested positive for anti-inclisiran antibodies. Maximum exposure for 6.8 years, total inclisiran exposure of more than 12,000 patient years. Injection site reactions were the only thing almost comparable with the placebo there. So the inclisiran first strategy definitely is a major maybe advance which you're going to face in the coming future. Thank you for your patient hearing.